Dear students, today we are going to talk with you about severe injuries. These are injuries of pelvis and spine. We will discuss with you the classifications, clinical science, principles of diagnostics, and of course principles of treatment. So let's start from pelvic injuries. So these are injuries, so-called pelvic fractures, are among very severe injuries of locomotor system. They are caused usually by a high energy force, such as car accidents, falling from the height, compressing with the heavy things like big stones, concrete blocks, heavy vehicles, etc. So pelvic fractures are, even if they are not associated with other injuries of human body, they can cause shock development in up to 30% of patients. So of course these patients should be admitted to the hospital and mostly to the intensive therapy unit. We should remember that lethal outcome for unstable fractures of pelvis can also be found in up to 30% of cases. So of course, we'll discuss later a classification, and of course not all fractures of pelvis are so severe. So if it is A group, less severe fracture, when pelvic ring is stable, maybe this patient can be treated in ambulatory conditions at home. But if we are talking about unstable fractures with vertical or rotational instability, of course, these fractures need more attention. They need specific treatment, and we talked already about very high lethal outcome. Involvement of hip joint is also very important for us, as acetabulum is a part of pelvis and it is involved in up to maybe 50-20% of all pelvic fractures. And of course, it is considered to be one of the most complicated injuries for diagnostics and treatment. Another thing we should note that osteoarthritis develop for acetabulum fractures, very common, and these fractures requires precise reduction. So in many cases, these are associated with femoral dislocation because acetabulum is a socket and it contains this femoral head. So if the continuity of acetabulum is disrupted, usually the femoral head can slip out of it. And one of the most common dislocations when fracture of acetabulum occurred, it is a posterior superior dislocation. So up to 80% of cases you can find it. These injuries may go with such severe complications as ischial nerve palsy in up to 10% of cases, avascular necrosis of femoral head from 5 to 20% of cases, as well as post-traumatic coxarthrosis, recurrent dislocations, and some others. Let's talk now about the pelvic anatomy. Pelvis is a ring and it is formed with such bones as sacrum on the posterior side. On the sides we have iliac bones, iliac veins, and on the anterior side we have pubic bones and ischial bones. So they are connected together with the symphysis, and posteriorly they are connected with a sacroiliac joint. So of course, besides these bones, we have many ligaments that are also responsible for pelvic stability. And if they are injured, we may have a severe condition, we may have a displacement of pelvic bones, and you should remember that there are various internal organs in the pelvis, so they may be injured, especially if we have unstable injuries. As well, we have a hip joint, which is formed with the femoral head and acetabulum. And if acetabulum is destroyed, this femoral head may go either inside in the pelvic cavity, forming so-called fracture dislocation, central fracture dislocation, or may go in one of four places, causing posterior superior dislocation, the most common one, posterior inferior dislocation, anterior inferior, and anterior superior. So all these four types are possible. Now let's talk about the ligaments, and they are responsible for pelvic stability. If we will look at the pelvic specimen from the anterior side, we will see the ligaments that are forming anterior ligament complex. These are anterior sacroiliac ligaments, sacrotuberous ligaments, sacrospinous ligaments. So anterior complex is responsible for rotational stability of pelvis. If we look at pelvic specimen from the posterior side, you will see the ligaments that are forming posterior complex, which is responsible for vertical stability of pelvis. These are short and long posterior sacroiliac ligaments, sacrospinous ligaments, and sacrotuberous ligaments, as well as iliolumbar ligament. Pelvic stability depends from anterior part of pelvis and posterior part of pelvis. So up to 40% depends from the anterior part and 60% from the posterior part. If we're talking about internal organs, so sometimes for displaced fractures, there is injury of bladder, urethra, rectum, and vagina. So when you are examining your patients with unstable pelvic injuries, you should check the damage of these organs. Various classification systems for pelvic injuries were developed. So why do we need classification? First of all, we need the classification to estimate patient's general condition, to predict is he hemodynamically stable or not. Another thing, we should predict the possibility of internal organs damage. We should predict whether this injury is stable or unstable, as unstable pelvic injuries can cause more damage for internal organs and they are more threatening for life. And as well, it is very important for our management to choose proper non-surgical or surgical management, to make a plan for surgical reduction, etc. Due to these, several classifications were developed, and one of the basic one is so-called anatomical classification, where we just name the bones that were fractured. So it may be a fracture of superior pubic rami or inferior pubic rami, ischial bone, iliac vein, sacral bone, coccyx, and etc. So this is simple classification and we use it in our practice. The second group of classifications that they are respecting stability and deformity. That's quite useful classification as the stability affects a lot on our choice of proper management. There's also Yoon and Barger's classification, which is respecting the vector force and associated injuries. And of course, OTA classification and AO classification, which we are using in our clinical practice. On this slide, you can see anatomical classification a scheme which shows you how the fracture can be broken. Note that anterior part can be broken in the pubic symphysis, maybe a fracture of superior or inferior pubic rami, the fracture through the acetabulum, posterior part when there is a sacroiliac junction, and oblique fracture of sacrum bone. The next very commonly used classification is tile classification. Actually, on this classification, AO classification was built. There are three types, type A, B, and C. Type A is less severe, type B and C are more severe. So, type A, these are stable fractures. For type B, we have some rotational instability, but there is no vertical displacement. And for type C, we have both rotational and vertebral instability. Also, according to the mechanical force that is applied, the injury of pelvic bones may be due to lateral compression, as is shown in the above row, anterior-posterior compression, and vertical shear, as is shown below. For better understanding of biomechanics of pelvic injuries, the pelvic ring is presented as a circle. So, due to this, the body weight is transmitted through the sacrum, sacroiliac junction, to the acetabulum and to the lower extremities. Note on the left side, when we have the circle which is not interrupted, this weight is transmitted without any problems. But if you look on the right side, we can see two fracture patterns. For the first one, we have interruption of the pelvis on two levels, so anterior and posterior part are interrupted. And due to this, there is a vertical shear of the hemipelvis. So usually it is displaced proximally. For the second pattern, we also have a rupture of pelvic ring, but pelvic ring is ruptured only in one place. Due to this, just very minimal displacement is possible. So for pattern 1, it is an unstable fracture of pelvis, and for pattern 2, it is a minimally displaced stable injury. A1 type fractures, these are stable fractures which are not involving the pelvic ring, so-called avulsion fractures. This can occur due to sudden contracture of muscle. That's especially in well-trained persons or athletes, and some parts of bones where these muscles are attached can be avulsed. So, the anterior superior spine can be avulsed by sudden contracture of sartorius. At the anterior inferior spine, usually a rectus femoris is attached. So ischial tuberosity can be avulsed by hamstrings, and posterior spine by erector spinae. And the crest can be avulsed by abdominal muscles. The crest and blade, these are fractures that also can be occurred by direct violence. Mostly for all these cases, we don't need surgeries. We can apply just a bed rest, but better to put the patient in some specific position where his hips and knees are flexed and abducted. We call this Volkovich position by the name of orthopedic surgeon who introduced this, and it looks like a frog position. So two names for this position can be used. The fracture of pubic bone, especially its anterior rami, is quite common injury. This is a minimally displaced, stable fracture of the pelvic ring. So it's one of the most common fractures for old ladies due to the falling on the side. So when you examine this patient, we should check the local tenderness on this side, and you can also ask the patient to raise his straight leg. That's not possible due to pain. So usually these fractures are not involving completely pelvic ring, these can be treated by a bed rest. So 2-3 weeks is enough, and better to put the patient in the Volkovich or frog position. Next fracture pattern are fractures of type A2. These are also stable fractures, but minimally displaced. Due to the pelvic ring is ruptured only in one place, there is a very few possibility to get a displacement. So different types of these fractures include fractures of both rami on one side. It may be a fracture of ilium running from the sciatic notch. It may be also a fracture of ilium or sacrum involving the sacroiliac joint. Though the nature of these fractures often suggests at least involvement of pelvic ring, these are usually uncomplicated and may be treated as a bed rest in Volkovich or frog position. Another type of fractures of A2 on the right side, it's so-called a butterfly fracture. So we have this fragment which is usually displaced but not significantly, and these fractures can occur usually from the anterior-posterior compression. So in some cases there may be such complications as injury of urethra, but usually these fractures are treated with a bed rest for 6-week period. So now let's go to next type of fracture. This is a B group fracture. Remember that B fractures are already unstable. We have rotational instability. And this picture shows very well so-called open book fracture. You see the pelvis is imagined like a book which this posterior part of pelvis is not damaged, but anterior part and anterior part of sacroiliac junction is ruptured. Due to this, we have the opening of the anterior part of the pelvis, and we have so-called B1 type open book injury. So for these injuries, we should already correct the displacement, and we should apply compression from both sides. So these can be treated with a pelvic belt if you are able to achieve reduction, or as well they can be treated with external fixator, which is applied on the anterior part of the pelvis. So when we are examining our patient with such type of injury, of course we start first of all from clinical examination. And when we look at this patient, you will see some hematoma and bruising at the sites where the force was applied. As well, we should palpate these areas, and local pain will be present at all parts of avulsion fractures or fractures of pubic symphysis, rupture of pubic symphysis, or superior pubic rami, or ischial tuberosity. All these areas you should palpate, and local pain you may review as one of the signs. Another thing that you should check also the rotational stability. So for this, you can apply anterior-posterior compression test or bilateral compression test. That's when you take your both hands and you're pressing on iliac crest from anterior to posterior, and you may feel some movement like the pelvis is opening and closing. The same is you can check from the lateral compression. You can compress iliac crest from both sides. You can feel as pelvis is moving. So these things should be checked. Of course, this should be checked very gently. And then you should continue with additional methods of investigations, as this will give you much more information about the fracture type and will allow you to plan your treatment. So the standard protocol is a so-called AP view of pelvis. This is a standard view, and most fractures and most severe fractures you can see on this X-ray. So it's much better to do a whole pelvis than just one hip joint, because in many cases you can miss a pubic fracture, which is very common for elderly patients. And if you check this X-ray, you may see that there is a fracture, so-called butterfly fracture of both pubic bones, and these are superior ramis and inferior ramis involved, and there is some displacement of this butterfly fracture. But much more information we can have from additional views, and these are 40 degrees caudal view, so-called inlet view, 40 degrees cephalad view, so-called outlet view, and we have additional oblique views like acetabulum judet view that can show you give you much more information about the displacement of these fractures, as the pelvis is not plane, it's like three-dimensional structure. But of course, the better information we should get from the CT scan, and now it is available in every hospital. So the question is, when to go with your patient to the CT scan? So I think if you make an AP view and you see that there is a fracture of pelvis, like pubic bone or ischial bone, and there is no significant displacement, you don't see vertical shear and you don't see rotational displacement, so that's usually enough just an X-ray for your diagnostics. But if you see that there is a vertical displacement or rupture of symphysis pubis, and you suspect some fractures of the anterior and posterior part of pelvic ring, so of course it is better to make a CT scan, and believe me, in most of the cases you'll find much more injuries and you'll be able to measure the displacement, and of course you will need this CT scan for a surgical treatment, because for displaced fractures in most of the cases the surgery is done. So this slide shows you how inlet view is done. So this view is very good to determining the posterior displacement of pubic bone, and also we can estimate how the pelvic ring look like. Is there any displacement inside? For outlet view, the main thing that is interesting for us and can be checked, this is the presence of vertical displacement. So it's much better to estimate vertical displacement on outlet view, and we can also check sacrum phenomena on it as they are visible much better. Also, when we are doing a CT scan, you can check not only Excel scans and Scout, but you can build so-called 3D reconstruction. And this 3D reconstruction can help you to imagine in 3D dimension how and where to these bone fragments were displaced. And that's very suitable if you want to make a surgery, so you know how to reduce this better. You can rotate this 3D model on your screen. You can look from the anterior side. You can turn it on some degree, look from some oblique views. You can also look from up and from down, and to see how these broken fragments are positioned. We were been talking with you already about undisplaced fractures and minimal displaced fractures of type A group, and usually these requires just stay in bed and a Volkovich position for a few weeks, like 3-4 weeks, depending on how many fractures are present there. But if we're talking about B group fractures, rotational unstable fractures, here we need some more advanced devices to treat these patients. And usually, if patient is hemodynamically stable, the non-surgical treatment is possible with a pelvic sling using a canvas. So this is applied under the patient, and the weight up to 4 and to 8 kilograms is applied through the pulleys. We use 2 Balkan beams on both sides, and we should make X-rays and check the position of the bone fragments. So usually we are able to reduce these, but if not, we can cross our ropes or we can increase the size of weight. And usually we're treating these injuries with a long period of time, up to 6 weeks is needed at least, and weight bearing is allowed after 8 weeks only. Another option that we can use for rotational unstable fractures or injuries, these are so-called pelvic belt. When the reduction of the pelvis is performed, this pelvic belt is applied, and if the position is good, it can be the main treatment. So the next type, which are vertically unstable, usually a vertical shift is present that should be corrected. So a skeletal traction should be applied for lower extremity on the injury side. But if we have a combination of rotational and vertical instability, we can combine a skeletal traction with a pelvic sling, or we can apply external fixator on the anterior part of the pelvis. Note that these external fixators are applied usually through the iliac crest in the area of anterior superior iliac spine. 2 or 3 shunt screws are inserted on each side, and they are connected together with a rod. So let me show you the example of treatment of unstable fractures. You see we have a rotational instability here, anterior part of pelvis broken and goes apart. So we should apply here external fixator, and that's actually was applied. Note that shunt screws were inserted in iliac crests, and they were fixed with a clamp to a rod. So external fixator was applied. Note if we have instability of both anterior and posterior part, the application of external fixator is not enough. So for these cases, you should apply a pelvic clamp on the posterior part of pelvis, and that will reduce the blood loss and improve the general condition of your patient. In some cases, when we have an instability of anterior part of the pelvis, like symphysis pubis rupture, and you can't correct this gap by non-surgical methods of treatment, we can perform a surgery and we can fix the pubic symphysis with 1 or 2 reconstruction plates, and it allows the patient to be rehabilitated much earlier. Another clinical example of a patient when you have a fracture of the acetabulum and it requires a surgery, open reduction and internal fixation of these fragments. Usually we use special reconstruction plate for these, the plates that can be modeled according to the shape, according to the curvature of the pelvis. Now let's talk about sacral injuries. This may be due to the anterior-posterior compression or lateral compression. As well, very common mechanism is a falling from the height on the area of sacrum. Mostly these fractures are not involving the pelvic rim, especially if they are horizontal, and they may be non-displaced and maybe also anterior, posterior or lateral displacement. In most of the cases, these fractures are uncomplicated, but it may be involvement of the sacral nerve roots, which can cause problems of sensation, and sometimes patient may expect weakness in the legs, and for these cases, later a surgical treatment should be done. Now let's talk about coccyx injuries. These injuries can happen in a sitting position when patient is falling on the stone or an edge of a step, and usually these fractures are quite painful. A very common clinical sign is that patient can walk normally without very little pain, but he can't sit because very intensive pain occur. Also, pain within defecation is very common for these cases. There were some types of coccyx injuries, like first type you can see the fracture is without displacement. It may be a fracture dislocation to the anterior side or to the posterior side, and a fracture with a displacement of the coccyx with a part of the sacral bone as well. So in most of the cases, non-surgical management is required, especially for non-displaced fractures. For displaced fractures, if there are some problems with sensation or problems with defecation, a surgical management can be considered either as a reduction of the coccyx through the rectum or maybe even in late period excision of the coccyx. Now let's talk about so-called fracture dislocations in the hip joint, as these fractures are of C-type, C3 type. These are considered to be the worst injuries with a very poor outcome. That is because the joint is involved and later osteoarthritis is very common, especially if the reduction of the fracture was not precise. So, what is a fracture dislocation of the hip joint? If you look at the right picture, you may see that the floor of the acetabulum is broken and the head of the femur goes inside into the pelvis. That is usually occurred due to the high energy injury, as patient is falling from the height on his foot and the force is transmitted through the femur to the femoral head and to the acetabulum. Another very common mechanism of injury is car accident, so-called a dashboard injury, when the patient hit his knee into the dashboard and the force is transmitted through the femoral bone to the femoral head and to the acetabulum, and the head goes directly in the acetabulum cavity and cause such injury. So another name of this injury is a central fracture dislocation of the femoral head, because the head is dislocated not to the posterior or anterior side, but centrally into the pelvic cavity. So if we will talk about the treatment of this condition, there are few options. Non-surgical options involves skeletal traction application, and actually two tractions are applied. One along to the femoral shaft, and the weight may be quite significant, from 5 to 7 kilograms, and another weight is applied along the axis of the femoral neck. So usually shunt screw is inserted into the femoral neck, and a weight is applied. So in many cases, by means of the skeletal traction, we can reduce the head into its position. And remember that there is a ligamentum teres capitis, which is attached to the floor of the acetabulum. So by pulling the femoral head, we can pull the floor of the acetabulum and put it on its place. And we can achieve reduction. Another option is a surgical treatment, which gives us the possibility for more precise reduction, and the plate is used to fix the acetabulum on its position. So that's all for today. Thank you for your attention.